When a transfer is occurring from maison de naissance, you have to realize it's usually because there is something wrong. There's something not going according to plan. That's sort of deviating from the normal trajectory of labor and something that requires some help or other interventions. So, and we try our best here really to provide you with a positive birthing experience, to welcome you, to work together to achieve the best possible outcomes, as I said. But usually when a transfer is occurring, some greater medical interventions will by necessity be needed, you know. So some of them that we can talk about, first of all, is that you may have multiple vaginal exams to check your cervix. Usually there's some slow progress, or there's a concern about the position of the baby or the descent of the baby. And so often we need to examine you vaginally and check your cervix multiple times, sometimes by a nurse might, and then a resident, and then a doctor. It might be different people involved. Usually as well, you'll need an intravenous when you arrive at the hospital. That's usually because there's a good chance we'd need to give oxytocin, which is a synthetic hormone that promotes contractions and stimulates the uterine muscles to contract. And so oxytocin, if the problem is a very slow and protracted labor, it's usually necessary and part of the care. As you said before, often an epidural will be necessary. That in someone who's progressing very, very slowly, that actually can sometimes help them relax, help their muscles relax, help them complete the dilatation as well. And usually as well, when you arrive at the hospital, as I said, it's for some underlying problem, and we usually will have to do continuous fetal heart rate monitoring instead of intermittent monitoring. So usually we will monitor the baby's heartbeat, and when you are needing oxytocin or with an epidural, our protocols are to monitor the baby's heartbeat continuously. Actually, even before getting to a C-section, another intervention that is sometimes required for your clientele, if they've reached full dilatation, like 10 centimeters, and the baby is low enough, but you know the pushing is not effective and the baby's not able to be delivered, sometimes we can, prior to deciding for a cesarean, we can sometimes do an assisted vaginal delivery, it's called, with either a ventouse, which is like a suction cup on the baby's head to help give some traction to assist with the delivery, or a forceps, which are metal instruments that we apply to the side of the baby's head. It sounds, you know, invasive, but it's actually can be quite effective. And we help pull with the maternal efforts to deliver the baby. If those options are not feasible or deemed safe or not at that stage yet, then a cesarean is often necessary. I think when Maisha and I have looked at the statistics of the patients that are transferred, probably a third of them will end up needing a cesarean for a medical reason. Cesarean is an operation. We make a small incision in the lower abdomen, and we make an incision in the uterus and remove the baby that way. There are, of course, more risks associated with an operative delivery like that, but we do it, you know, many times very safely. The risks are quite low, and we're very skilled at that. One thing that patients should know is that how and where we do cesareans at our hospital is a bit different based on the time of day or night. So during the daytime, we can do cesareans upstairs in the birthing center. We have our own operating rooms and recovery room, and that functions, and we have the resources to staff it till about 3 o'clock in the afternoon. So a cesarean that occurs during that time, on days, the mother would go to the recovery room, partner and baby, they can stay together as a unit. However, after 3 o'clock, cesareans are done in the main operating room. So on evenings, night times, and weekends, cesareans are done in the main operating room. and then the recovery occurs in the main recovery room. In those situations, the baby cannot stay together with the mother for a period of approximately 2 hours post-operatively for observation of the mother to make sure that the anesthetic and everything is okay. And the baby would go with the father up to the ward, and they can stay together, and the father can do skin to skin. And usually after about 2 hours, the mother is transferred and can be reunited. So that's sort of how the cesareans work. One thing for the cesareans, even though I know it's probably quite disappointing for a patient to have a cesarean, we still do our best to make it, you know, as positive an experience as possible. The partner is always allowed to stay with the patient during the cesarean. They're almost always done under epidural or spinal anesthesia, so they're awake and they can see the baby right after. It's very rare to require a general anesthetic for a cesarean. And we always do our best, you know, to do some skin to skin in the operating room, even in that situation of a cesarean, so that you can have those first, you know, 30 minutes together of skin to skin. So that's something we always attempt to do.